We're going to go over the AHA STEMI guidelines. These are, you heard Diane already talk about the controversies and how weak the database is behind some of these. And then you heard Dave do the STEMI guidelines, which are a little trickier, I think. And now we're at the STEMI guidelines, which are a little bit less tricky because STEMI is pretty self-apparent. And although we could have the broader discussion of how in the United States we're very intervention-oriented for these, and we take them all to cath if we can. If you're in a cath-capable hospital, they'll go to cath. And if you're in a non-cath capable hospital, you might transfer a lot of these and have transfer agreements. So just before we start, how many non-cath capable hospitals do we have here? So a pretty good mix. So we're going to talk about both of those processes. But as I say, we could have this broader discussion of how they don't do the same interventional approach in other countries. Having noted that, that applies mostly to the STEMIs, many of which get cath in the United States, just not emergently. They get cathed after they're cooled off and medically managed for a while. So let's talk about this a little bit. I really like the first study. It's a Danish study that says, we thought it was a STEMI, it had ST elevation. It just wasn't an MI when we got to the cath lab. And this is important because we talk about things like stroke mimics when we talk about giving lytics to stroke, and stroke mimics are really important there. So this paper is really about STEMI mimics. It's not like they mimicked having an ST elevation, they did, but it wasn't an MI. So what was it? And the gold standard here was they took them to cath. And there was no occlusive lesion, no culprit that fit with the ST elevation distribution, et cetera. And in this study, there were a variety of non-acute coronary syndrome diagnoses, including Takotsubo syndrome, so-called broken heart. Do you know about that one? This happens, we see it a couple times a year. I wrote a paper about it some time back. But it's usually where a mom comes to see her kid who's been horribly injured in the surgical ICU or just died, and she collapses and grabs her chest and gets brought down to the emergency room, and you're like, Jesus, it wasn't bad enough that I was busy from the front door, but now I got the units dropping bombs on me from upstairs. And you get an EKG and there's ST elevation, and you call your cardiology colleagues and they take her off to the lab, and when they get there, her vessels are clean, but she has an unusual shape to her left ventricle. It's dilated near the apex, and it's not performing well. And they might even have troponin elevations. What this is not clear. There's some people think it's about the adrenergic storm that happens in the setting of her grief. And it can be anyone with a very powerful emotional experience. By the way, both happy or sad can do it, but it's about 85% of the time it's a death notification. The reason it's called Takotsubo is because it was identified in Japan, and taco, if you're in a sushi restaurant, gets you an octopus, and subo is pot. And so when the Japanese put these pots out to catch octopus, they have the exact same shape as this left ventricle does when you fill it with dye, and hence the name Takotsubo, which identifies that it's a functional abnormality of the left ventricle without associated coronary artery occlusions. So they found some of those. They found some intracranial hemorrhages where they got deep T-wave inversions and some ST elevations. And that's also believed to possibly be microinfarct. And indeed, even sometimes the troponins will be positive in that. They found some pulmonary conditions. I've definitely seen pneumothoraces with ST elevations. Usually they're relatively complete, but PE can do it every once in a while. And then those are the ones they actually found. By the way, the biomarkers in these non-ACS diagnoses in this series were positive in half. So about half of them had positive troponins, ST elevation, and it wasn't acute coronary syndrome. So put that in your pipe and smoke it. And if we make the list, the complete list, it would include things like pericarditis, it would include big-time left ventricular hypertrophy with repole, it would include Takotsubo, cerebral T-waves, the pulmonary conditions. Another common one is someone who's got known coronary artery disease who had an infarct weeks or months ago, who's got an LV aneurysm, and that aneurysm is causing ST elevation. Benign early repole can fool you sometimes. Pacemaker misreads are sometimes odd because of where the lead is placed, and things like that. So the fact of the matter is that even if you read EKGs and are fairly sophisticated in it, and you even using them in combination with biomarkers, you will call and activate the cath lab, and when they get there, they will find stuff that is not acute coronary syndrome. So if you just start with that, that's going to be about 5% of all your activations. So anyone who says that there should be no false positive activations, they just don't know the clinical reality. There's other stuff out there. That we haven't even gotten to what is your level of sophistication in reading the EKG, and I think Mallon and others who are big educators in emergency medicine have done a lot to improve our communal emergency medicine skill set with reading EKGs, but we have a couple EKGs here to show you. And abstract 2 by Hennings wants to talk about AVR. Somebody up here asked about, and yesterday I asked, who's giving the STEMI lecture? Not realizing it was me today. Usually the person who does the AHA lectures does all 3 of them. And this course, we had Diane do one, Dave do one, and now me doing one. But in any event, abstract 2 has that EKG there, which shows AVR, ST elevation greater than V1. We talked about this yesterday. That's an MI. So that's an important pattern to recognize, and a lot of people kind of ignore AVR. Now, if AVR is less than V1, it might be a STEMI, particularly if there are reciprocal changes. But if AVR is greater than V1, it is a STEMI. There's another EKG. The next EKG in the a couple pages over is another paper there's another EKG that they want to talk about AVL having ST elevation. In that EKG, the EKG is not very subtle. I mean, you look at that AVL and go, I don't often see a tombstone in AVL, but I think that's a tombstone, and it is. And how do you know that that is what it is? Because it has ST depression in the inferior leads, which are reciprocal to it. It also has V2, I think, with some ST elevation, and so that's pretty clearly ACS. There are some other places where you can improve your reading of EKGs. So when we talk about left bundle branch block, we know that a left bundle branch block is concerning no matter what. The presumption may be when you see someone with acute chest pain that this is a new left bundle branch block. And if it's a new left bundle branch block, that's very concerning. If you have an old EKG with a left bundle, it's less so. But a new left bundle is very concerning and is generally agreed upon as a reason to activate the cath lab, but especially when it has Scarbosa's criteria. But all the Scarbosa criteria do not perform equally. So the Scarbosa criteria where you're trying to identify how much ST elevation there is in a left bundle branch block where the J point is hard to determine where it is, and you're trying to say, is that 5 or 6 or 7 millimeters? That's hard. That's hard to do in V2 and V3. But remember that in a left bundle branch block, whichever way the QRS goes, the T wave should go the other direction. That's called appropriate discordance. QRS up, the T wave should be down. If the QRS is down, the T wave should be up. And in particular, there's a Scarbosa criteria that says in V5, V6, where the QRS is up in a left bundle, if the T wave is up, so that's inappropriate concordance in the setting of a left bundle, that is by far the best of the Scarbosa criteria. So you got a lateral lead, V5, V6, where the QRS is up and wide, left bundle branch block pattern, and the T wave is up, like it shouldn't be, with or without ST elevation, often with a millimeter or so of ST elevation. But that, of all the Scarbosa criteria, is the most important, most objective, has the highest specificity. Doesn't have tremendous sensitivity, as you have gathered throughout this course. You never get specificity without dropping in sensitivity. All right, abstract 3 is by Ivan Rokos. He's a kid I trained who then went on to Olive and UCLA. He helped set up our system in Los Angeles to have STEMI receiving centers so that the smaller non-cath capable hospitals would be bypassed with these patients and they would be brought directly to a STEMI receiving center. And he worked hard with the cardiologists, and during that time, the cardiologist slipped him some Kool-Aid and he drank it by mistake. Around that time was when he was working with them, because there were a couple cardiologists, notoriously one at Diane Birnbaumer's place, who used to say that the false positive cath lab rate should be under 5%. This is bullshit. We get called in and we have to, you know, and it's not even the real deal. I can't even bill the patient for a revascularization procedure. I'm sorry that you weren't able to make a payment on your vacation home in a gated community in Vail. But we did our best, and it just happened this was a false positive, and that rate is gonna be, it's never gonna be under 10%. By the time you factor in subtle reads of EKGs and other diseases that genuinely have ST elevation but aren't ACS, you're gonna have a false positive rate of in that range, 10, 15%, even if you're doing a fantastic job, you're not gonna get it underneath that. All right, so having noted that, if you got a cath lab, you wanna do your best. When you do your best, you wanna get the cath lab engaged early, and there's in all these STEMI centers, and many of you are at one, you know, there's all this emphasis on door-to-balloon time and notifying them and getting everything done, and we'll talk a little bit about that. But for those of you who aren't at a cath-capable hospital, and many of these patients aren't brought by paramedics, they walk in. So even if you have a full EMS system set up to direct all the STEMIs to STEMI receiving centers, all the STEMIs won't go to receiving centers because some people just walk in from the, you know, from the theater next door with chest pain, or, you know, from, I was just driving by and my chest wasn't feeling good, and they come in, they're STEMI. So they're gonna arrive, STEMIs are gonna continue to arrive at non-STEMI receiving centers. That's just how life is. And what should you do with those? Well, there was a big trial, and it's not in here, but it's in the database. It was called the PORT trial that said if you have agreements and you can get them to a STEMI-capable, a cath-capable hospital really quickly, that overall the outcomes are better, and so we should do that. All right, but there's a lot of assumptions in there, which is you can do all that, and that the agreements are there, and that they're willing to take them, and you have a way to make that happen quickly. What if that's not the case? And so we have a couple papers here. Abstract 4, I think, is really worth looking at. It's an editorial. There's, you know, sometimes people have good things to say, even when there's no data in it. And it says, really, if you see a person in the first 90 minutes to 3 hours of their symptoms, not arrival time, of their symptoms, and they got a STEMI, your job is to open that vessel as quickly as possible. And we know that if you open that vessel, it's the breaking point for almost making like the heart attack didn't happen is around, you know, 75, 85, 95 minutes, somewhere in there. If you can really reopen the vessel, it's almost like the heart attack didn't happen. You revascularize them, they reperfuse, they do really good. They have excellent cardiac performances with near normal ejection fractions down the road. They do great. As you go further out in time, revascularization has less and less value because the distal heart is dying progressively more and more, and it also depends on sort of what their baseline is and whether they have collateral vessels and things like that. So this paper says, really, if you're in a really remote place and you got a person who's in that acute phase and you can't get them out of there promptly and get them to a cath-capable hospital, then give them lytics, because that will open their vessel up. Go back to the old TPA protocol, or whatever you use, tenecteplase or whatever you got, whatever your lytic of choice is at your hospital in a STEMI, and give it. These authors are from Alberta, and in lots of Canada, where there are these rural hospitals, getting someone to a STEMI center means either a helicopter or even more frequently in some of those rural places, it means getting a fixed wing. That is not happening in an hour and 20 minutes. You're not going to get them to a cath-capable hospital from northern Alberta down to Calgary in under 120 minutes. So this author says, don't be crazy. If the system is just not going to make it happen quickly, lice them, revascularize them now. And that maybe some patients have been harmed by trying to do this transfer to a cath-capable hospital without giving lytics. And the AHA says that if you're going to do this transfer, they really need to get to the place in under 120 minutes so they have relatively prompt initiation of their revascular procedure at the referral hospital. Abstract 5 says, so let's just say you're in a city, an urban environment, you're not in rural Alberta, but you're not at a cath-capable hospital. This is for all of you who work at smaller hospitals that don't have it, but might have a STEMI receiving center down the road or nearby. They say, well, what are the ways that you can have a STEMI who walked in or was brought in by a paramedic get out of there and get to a STEMI receiving quickly? And there are two ways you can do it. One, if they're brought by paramedic with chest pain, you don't let the paramedics leave. Stand by one, that's the lingo they like. Stand by one, we're just going to get an EKG and check this out. Okay, we're putting them back in your rig, take them over there. You know, they'll do a few things, give the aspirin, give some nitrates, do some stuff, package them up, go. But don't let them leave, because if you let them leave, now you got to call it to the ambulance, it's going to take some time, they got to get there, you got to call the receiving hospital, there's a lot to do. Whereas if you don't let them leave, your DIDO time, as they call it in Abstract 5, door in, door out, for the non-cath capable hospital will be too long. So that's one way, is hold the medics. The other way is you have to have one of your own hospital's ambulances sitting there nearby the ED pretty much all the time. So that when they walk in, so there's no paramedic to hold, you have an ambulance to send them to the cath capable facility. So what they say in Abstract 5 is you really want to work on your DIDO times. If you're a non-cath capable hospital that has transfer agreements to a STEMI receiving center, the most important thing you can do, other than just treating them as they arrive with the appropriate things, is have a way to get them out of there quickly and really focus on your DIDO times. This Yale study that looked at 14,000 STEMIs that were transferred said that the median DIDO was 64 minutes. Youch, that's too long. You're really eating up time before they get to the transfer center. That was the median time. And only 9.7% of the transfers had a DIDO time of under 30 minutes. Really, you'd like your DIDO time to be 30, 40 minutes. They come in, you figure out it's an MI, let's get them out of here. You know, get them hot to trot, package them up, go. You'd like it to be short. In that Yale study, number 5, it was worse if it was rural. It was worse if it's a government facility, because the government facility is worse because, of course, you need committees to get it to happen. And, you know, what's a definition of a committee? This is an academic definition of a committee, but an academic definition of a committee is where you get all the stakeholders together and make sure that every stakeholder is equally unhappy with the outcome. That's the purpose of a committee. Not to do the right thing, just to make sure that all the stakeholders are equally pissed off. That's why grandstanding in those committees is so important. You have to make your pistivity look greater than their pistivity. It's good if you can have like a vein. I like to apply some nitro to the side of my head before I go to those committees, so the veins on my forehead stuff will stand out. Because then they're like, Jesus, his head was going to explode. He's more unhappy than us. Maybe we can give a little. That's how you do that. All right. You didn't know that was the use of nitro. We see what, you know, in East LA, right? You know, Viagra's expensive, and a lot of our patients can't afford it, so they go to Mexico and they get Mexican Viagra, which is rattlesnake capsules. Something about the snake for the snake. That one-eyed monster will enhance my one-eyed monster. That kind of thing. And the rattlesnake capsules are often contaminated with salmonella. So there's nothing like explosive diarrhea to end your amorous instincts. So while it doesn't work in terms of producing tumescence, it does destroy the urge for sex. So it's fairly effective. But they also apply nitrates and things to their penises. And so one of the causes of headache in our hospital is a woman who had sex with a man who had nitrates smeared all over his penis, because her vaginal surface area for absorption is greater than his penile area. And plus, he's been doing it regularly, so he's tachyphylaxed to the headache. But, you know, she comes in, I have a post-coital headache. You're like, could be nitro. But I digress. Abstract 6 is another one that says, when you have an MI patient in this very early period and it's really critical, you want to reperfuse them as early as possible. And if that can't happen by transfer, then give them lytics. And the American Heart says that if you're going to do lytics at the primary receiving hospital that's not cath capable, that you still want your door to drug time to be under 30 minutes. So if you're going to make the decision, make it, get the drug up. All right. Now we have a bunch of papers, 7 through 11, that are about the cath-capable hospital, so you're a STEMI receiving center, likely. And it points out that door to balloon time is more important in the early presenters, just as I said. You want to reperfuse those early presenters as soon as possible, but it doesn't continue forever. It doesn't continue to time 0. So for example, in abstract 8, where their cath time was 83 minutes, their door to balloon time was 83 minutes, so they're in the window of really doing a good job on these early presenters. They're right there. And so they decreased their cath time, their door to balloon time, to 67 minutes. All right, sis, boom, ba, rah, rah, high fives all around. We're doing good with our system. Everyone's a team player. Yup. But it didn't change the outcomes because you were already in the window. If you change from 120 to 87, that's going to be high yield. You change from 87 to 60, not much yield. You change from 60 to 45, probably not much yield from that because you're already in the optimal window for revascularizing this acute process. So yes, you want your door to balloon time. Now that's all assuming that the symptom time beforehand is equivalent. If the symptom time beforehand is long, then having a shorter time could still make a difference for those patients. And that's what abstract 9 says, that S2B, symptoms to balloon, is important. And if you look, it's interesting, if again, I'm at a county hospital, and so in the Hispanic populations, they just don't know to call 911. They don't call it for stroke, they don't call them for MIs. You know, they hang around, they wait for someone to come home from work with the car, then they you know, can you take me over in the minivan? Then they drop, or they take 3 buses and then they walk the last 200 yards so they can have a stress test on their way into the hospital, things like that. But the way to fix that, the only way to fix that, and this paper points it out, is really with awareness. In my hospital, that would mean getting onto the Spanish language channels at SANA and Univision and having public announcement campaigns where you address the communities that aren't accessing 911. That's been shown, by the way, not just in Hispanic communities, but it's been shown in the black communities in the South. When they wanted to teach people how to do first responder in the Atlanta area, they realized that when they looked at bystander CPR, that the black community wasn't participating in it. And it wasn't because they had any objections to it, the education just wasn't reaching them. So they decided we're going to do a CPR program in the churches around Atlanta. And that really changed things because they found a way to educate the community, a vehicle to get to them that would really work. All right, 10 and 11 say, and how many again are at a STEMI capable STEMI receiving center? So a lot of you. So how many of you allow the EMS, the EMS people get an EKG and it says star, star, star MI. How many of you fire up the lab based on the field? Some. How many wait for them to get to the ED for the ED doc to look at them? Couple. We do at our place because they complained about all the false positive activations. So he said, at least let us get a look at it. We don't think it's, our cath team, we got fellows and a whole cardiology program. The hospital part we know is going to be quick. So we said, all right, let us have a sec to look at it. So I'll take you, Mary, first. We'll move around.
Paramedics send us the EKG on phone.
Oh, so you get it electronically? That's nice. And some people have said, why would you ask me? Send it to the cardiologist by Bluetooth. What's the problem with that? What's the problem with sending it to the cardiologist? We know that they won't come in on nights, weekends, and holidays. So you can't ask them to look at the EKG because if it's a night, weekend, or holiday, they'll say it's negative. You have to have an independent of them and their sleep and their schedule person look at it. Yeah. So what happens if you allow the EMS people to do it? How good is that EMS EKG that says star, star, star MI? It's got a sensitivity of that's high, 99%, but the accuracy is low, 70%, 78% in one, 75% in the other. So in abstract 10, you're going to have 25% false positives if you're going off the field EKG. If you don't allow a slightly more trained doc to look at it and try and trim some of those down, you're going to have more false positives. So it says if you're going to go by the field EKG, the best you can hope for is 75, 80% to be on, and 15 to 20% are going to be false positive activations, just based on the field EKG. How do you minimize delays if you work at one of these places? And I expect most of you who work at a cath-capable hospital have this already, which is you do single call. There's one call. You have a code STEMI, you call it, and it notifies the nurses for the cath lab, the cardiologist, the fellow, the whole team gets boomed, and they all come. And that single call strategy is looked at in 12 and says it works. Change their cath times, their door to balloon times from 129 minutes before single call to 77 minutes in that optimal time afterwards. So that's good. Now we have a bunch of other STEMI stuff to talk about other than cath, which is, are we still doing hypothermia? We reviewed these papers that say hypothermia is a little bit of trouble. Abstract 13 talks about this, but it is still the AHA ACC recommendation that if they have Roski without Ronfi, you cool them to 34. And we're doing it, even though we know. How about antithrombotic therapy? Aspirin, still in for almost everyone before PCI. Are you loading with Plavix or Prasugrel or Ticagrelor? Most people are using Plavix, clopidogrel, we are. So 600 milligram loading dose, let's remember if they're pre-PCI, it's a high dose. 600 milligrams versus the daily dose, which is 75 milligrams. 14 looks at that and says yes. We sometimes defer this to the cardiologist, but most of them want that. What's a situation where they might not want it? If they're suspecting that they're going to get in there and the person's going to need bypass surgery, how happy is the cardiothoracic surgeon that you loaded them on an antiplatelet agent? Not very happy. Not very happy at all. So it means that rescue from a cath to a cabbage is going to be problematic. So if you want to sit tight on the 600 of clopidogrel and have that conversation just before they go to the cath lab, I got no problem with that. And then how about adjunctive therapy like unfractionated heparin and the glycoprotein 2B3A inhibitors? This is where the American Heart gets ridiculous, right? The American Heart has class 1 recommendations, class 2 recommendations, and class 3 recommendations. But because when they got to 3 at the American Heart, they thought they were running out of numbers. They're like, Jesus, we're up to 3 already, we better slow down. I mean, how far do these numbers go? So then they broke 2 into 2A and 2B because they couldn't go to 3 and 4. They said, we better have 2A and 2B. So one of the ultimate ironies is that a glycoprotein 2B3A inhibitor is a class 2A recommendation. It's like, oh, Jesus. Stop it. Anyway, I digress. How about beta blockers? So remember we had that commit trial which said you give beta blockers to this MI patient and suddenly they slow down, they develop a block, or they get worsening heart failure, and so we all went away from it. But a large number of MIs are hyperdynamic, hypertensive, diaphoretic, and it really makes sense to give them a little beta blocker. What do they say now in the American Heart? They say you don't do them IV, you can go ahead, it's a class 1 recommendation that it's okay to give them orally, so the old 5 milligrams of metoprolol IV is gone. But if you want to give a beta blocker orally, that's fine. Oral is preferred to IV if you're going to do it. It's a class 2A recommendation that if they're hypertensive, tachycardic, and have no contras, go ahead and beta block them with an oral pill, 1 pill. Here's a Tenolol 50 or something like that. And when should you avoid beta blockers? That's abstract 15. They're old, greater than 70. They got a low blood pressure. They got heart rate issues, and their symptoms are more than 12 hours, long symptoms, because those are the risk factors for them getting worse. How about statins? They're going to the cath lab. You're like, yeah, they're going to be on statins forever. Why do I care about statins? Well, there is this ongoing literature that says that early loaded statins have a different effect than lowering your cholesterol. They have a vascular effect, that the HMG-CoA reductase inhibitors cause a microvascular change, an endothelial cell function change, they stabilize plaque, they're anti-inflammatory, they're a bunch of things, and repeatedly when they look at those given statins before they went to the cath lab, loading dose statins, that in the post-cath period, their rate of post-procedural MI is lower. Their rates of MACE, major adverse cardiac events, is lower. Their troponins and CPKs are lower. So if you look at abstract 17 is really the one I think, and there's a couple like this. It's a Korean paper, 445 STEMIs, all of whom weren't on statins already. So they were statin naive. So that's where you're really going to see the benefit of loading them on a statin. And they are all treated by all the usual things. And in the statin group, they had a 5.8% rate of post-procedural MI. No statins, 11%. That's a pretty big difference. The rise in CKMB and troponins were less. The CRPs were lower and the MACE rate was lower. So I don't have a problem. If someone wants to load someone with statins, like 40 at Crestor before they go to the cath lab, with a normal dose being 10, have at it. There are a couple meta-analyses there, 16 and 18. There's new papers that have come out in the last 3 months talking about this, a big one by a guy named Benjo that really is a pretty good analysis. And so you'll probably be having your cardiologist ask you to load on statins. I don't see a big downside to it. So give a statin load dose before they go to cath. And then finally, a thing about hyperoxia, paper 20. So, remember we used to say, MI? You give them MONA, morphine, oxygen, nitrates, and aspirin. Well, now they don't like the morphine. They'd rather know whether the patient's having ongoing pain. I'll still give morphine occasionally if they really need an anxiolytic, because a lot of them do. They don't want you to give them the oxygen because we've been learning over the years that hyperoxia isn't helping them. So only give oxygen if their SATs are low or they're having respiratory symptoms, shortness of breath, or other things. By all means, we're not saying deprive someone of oxygen who needs it, but if their SATs are good and they're doing fine, and I'm not sure I would walk in the room after the nurse put them on aspirin and rip the prongs off and say, don't you know anything about the new recommendations? But having noted all of that, they're downplaying oxygen, and that's not just an MI. So the anti-oxygen recommendations are extending to stroke, they're extending to, it's all this free radical stuff, and that the hyperoxia causes problems. Cochrane's on board with it, the AHA and the ACC is on board with it, and even the NICE guidelines in Europe saying, yeah, hold the oxygen unless they need it. It's a treatment, and hyperoxia is repeatedly associated with, not causally proven, but repeatedly associated with worse outcomes in a whole variety of diseases, not just ACS. And so that takes us to page 184 with the final recs that you can look at. One of my pet peeves about this stuff is, do I really need a new frickin' guideline every couple of years to pay attention to every little penny ant change that they want to make that can be picked up? Because it's when it's been asked, who really knows these guidelines? It ain't the docs. We don't pay attention to them. There's just too many of them. It's the paralegals who know them best, because the lawyers aren't going to read them either. The lawyer gets these guidelines and goes, shit, hands them to the paralegal. Tell me what these say that our guy didn't do, or did, if they're on the defense. So I don't know if I need to prepare more guidelines for lawyers. Are you up next, Dave? And Dave is up now.